We are going to discuss Unit 5, the cardiovascular and circulatory system. Okay, so the cardiovascular system, also known as the circulatory system, is responsible for transporting oxygen, transporting nutrients throughout the body, transporting hormones that we talked about in our endocrine lecture, and transporting waste products throughout the body. Our organs that we're going to talk about and pay attention to consist of the heart, the blood vessels, which contain the arteries, veins, and capillaries, and the blood itself. The cardiovascular system's main function is to deliver oxygenated blood to tissues and remove carbon dioxide and metabolic waste, which helps to maintain homeostasis. When we look at the organs of the cardiovascular system, we first start with the heart. This is a muscular organ, so it is very muscular, and it's located in the thoracic cavity. It's typically to the left of the midline behind the sternum. When you look at the heart itself, it is made up of 4 chambers. So on the right side of the heart, we have the right atrium, which is that upper chamber of the heart. This is what receives deoxygenated blood from the body, from the superior and inferior vena cava, and then we have the right ventricle. This helps to pump deoxygenated blood to the lungs via the pulmonary artery. When we look at the left side of the heart, we have the left atrium. This is the top part of the heart on the left side. This area receives oxygenated blood from the lungs through the pulmonary veins. So that blood comes back in through the pulmonary veins after being oxygenated from the lungs. On the left bottom part, we have the left ventricle. This helps to pump oxygenated blood out to the body, and that's going to go out through the aorta. We look at the heart valves. These are one-way valves that help to ensure proper blood flow and help to prevent backflow into the heart, into the lungs, and into the body. So they are one way. We have our AV or atrioventricular valves. These are our tricuspid valve between the right atrium and the right ventricle. The mitral or bicuspid valve, which is between the left atrium and the left ventricle. And then we have our semilunar valves. So that's your pulmonic valve between the right ventricle and pulmonary artery, and the aortic valve, which is between the left ventricle and the aorta. Sometimes when we're talking about heart assessments, these patients may be told that they have a heart murmur, which is what you will hear with the backflowing of the blood when those valves don't close properly. So you'll kind of hear that like whooshing sound of that blood. So for our blood flow through the heart, our blood goes from our body to the right atrium, to the right ventricle, out to the lungs, gets oxygenated, goes into the left atrium, through the left ventricle, and out to the body. When we look at our coronary arteries, that's the picture on the right-hand side, coronary arteries help to supply the myocardium with blood. They are essential to help supply oxygen-rich blood to the heart muscle all the way down and throughout that heart muscle, and help to ensure proper functioning of that cardiac system. For our problems with our heart, we're going to talk a little bit about dysfunction of it, but typically with that blood flow, if that left ventricle fails to pump effectively, you'll see symptoms in the pulmonary system. If it's the right side or that right ventricle that fails, you'll see problems throughout the body, so systemic symptoms occur. And we'll talk more about those in subsequent slides. Okay, so we're going to talk about cardiac hemodynamics. So when we look at cardiac output, or CO, this is how we determine the amount of blood that the heart pumps out each minute. So to calculate that, we take the stroke volume times the heart rate itself, and that will give us the amount out. So for example, if our stroke volume is 70 mLs of volume every beat, and we take that, multiply it by the heart rate of 70 beats per minute, we would get a cardiac output of 4.9 liters per minute. Factors that can decrease our cardiac output would be things like hypovolemia, so lack of volume, heart failure, where the heart is not pumping effectively, dysrhythmias, which is an electrical current, inappropriate electrical currents in our heart, or decreased contractility, for example, in a myocardial infarction. So we'll talk a little bit about these disorders, but just know for our basics for cardiac output, it is our heart rate times our stroke volume. When we look at our preload is the amount of blood volume that returns to the heart to be able to go through the heart itself. And our afterload is the resistance that those ventricles have to overcome to be able to exit the heart itself. When we talk about contractility, this is the strength of the cardiac muscles and how strong they squeeze to get the heart out, or the blood out of the heart. Okay, so now we're going to talk about the electrical conduction pathway for the cardiac system. The cardiac electrical system is kind of a network of nodes and nervous impulses and pathways that controls the heartbeat by transmitting electrical signals throughout the heart. If you see here on the picture, typically our heartbeat first gets signaled or initiated through the SA node. So that is called our pacemaker. This is our intrinsic pacemaker of the heart. This pacemaker has an intrinsic heart rate of 60 to 100 beats per minute. So this is what sets our rhythm and initiates the impulse to occur. Once that electrical impulse occurs, it then will travel to the AV node. This has an intrinsic heart rate of about 40 to 60 beats per minute. And this is where the impulse kind of slows a little bit so that it allows the ventricles to be able to fill up. Then if you see the pathway, it continues from the AV node and will electrically impulse down through the bundle of His. This is what transmits the signals to the ventricles. That electrical current will then go and hit the bundle branch area. So if you see, it kind of bifurcates off. The bundle branch area is where this electrical impulse will conduct down through the septum. So the septum is that middle wall of the heart, and then it will go down either the left bundle branch or the right bundle branch and be able to go on to both sides of the heart itself, down through the ventricles. Once it goes down through the bundle branches, it will then conduct down through the septum to the Purkinje fibers, and this has an intrinsic rate of 20 to 40 beats per minute. This is what then stimulates the contraction to occur in the ventricles. So that electrical impulse happens very rapidly. It is controlled by the autonomic nervous system, which we talked about in our neuro lecture. Our sympathetic nervous system is what increases our heart rate, and our parasympathetic nervous system is what helps to decrease the heart rate. Okay, when we look at the cardiac cycle describes one complete heartbeat. This includes the events of contraction, so that heart contracting and squeezing, and relaxation, which is that heart muscle relaxing and filling with blood. Both the atria and ventricles allow blood to move through the heart and help to circulate it through the body. And so this cycle, one full complete heartbeat, includes two major phases. There is the diastole. This is where the heart relaxes and fills with blood, and the systole, which is where that heart contracts and pumps the blood out to the body and the lungs. During the diastole phase, this is where that muscle relaxes, the atria and ventricles are relaxed, and so blood's able to return to the heart. If it's coming from the body, it returns to the right atrium. If it comes from the lungs again, it returns to that left atrium. Both the AV and tricuspid and mitral valves are open, and so that blood can flow freely and fill into the heart. With our end diastolic volume, this is the amount of volume, the amount of blood in the ventricles at the end of filling just before the next phase of that contraction occurs. For that second phase, the systole, which is our pumping phase, this is where those ventricles will contract. The AV valve then closes to help prevent black flow from occurring, and this is what produces that S1 heart sound, so that lub sound for the lubbed up. Pressure builds up and forces the pulmonic and aortic valve to open. The blood is then pumped from the right ventricle into the pulmonary artery into the lungs, and from the left ventricle into the aorta and the body. After that blood is ejected or pushed out, those semilunar valves will close, and that's what produces that S2 sound, which is your dub sound. Once those ventricles relax, that cycle starts again. So that's your phase of the heart, the cardiac cycle. So one complete heartbeat has both the diastole and the systole phase. Okay, so I'm sure you guys have all gone over cardiac assessments in depth in your head to toe assessments as well as fundamentals classes. So you all know how to listen to heart sounds, listen to the ape to man, do pulses, peripheral pulses, check an apical pulse, those types of things. But there's a couple things just to review. So for our cardiac assessment, this is going to evaluate our perfusion, how well that heart is pumping the blood and maintaining perfusion throughout the body. You're going to include both subjective, what that patient tells you, and objective assessment data. So when we look at subjective assessment data, our patients may report things related to their cardiovascular system like chest pain or pressure. Oftentimes they'll feel that in that heart area, the left side of their chest. They may have shortness of breath or dyspnea, especially if it affects that pulmonary system as well. They may have things like palpitations or fluttering in their heart, depending on if that affects the neurological system or that cardiovascular impulse. They can have fatigue or weakness if there's decreased cardiac output or if it affects the lungs from fluid overload. They may have edema throughout the body. This can be due to fluid retention from a heart that's not pumping effectively. They can have dizziness or syncope, especially if they have problems with their blood pressure or poor perfusion that's causing some arrhythmias to occur. You might see patients that have problems with their legs and their extremities related to exercise, movement, or just vascular destruction itself. For our patients, they may have problems with orthopnea, which is difficulties breathing when they lay flat, or difficulty with nocturnal dyspnea, which is problems with sleeping at night. This can be a sign of heart failure, which we'll talk about later. You may also see things related to weight gain as well, and this is oftentimes a sign of cardiovascular problems. For your objective cardiac assessment, again, you're going to do your physical assessment. So we're looking and listening and feeling. So when we're looking, we're inspecting the skin, looking for proper coloring for ethnicity, looking for that jugular vein distension, any edema throughout the body. What's their breathing effort and position look like? Because remember, cardiac and respiratory systems go hand in hand. And then their capillary refill, is that less than 3 seconds, which shows good perfusion. When we're listening, auscultating, we're going to listen to our areas of our cardiac system, our heart, which is our aortic, pulmonic, herbs, tricuspid, and mitral area, so that ape to man. And what we're listening for is the S1, which is that lub sound, and the S2, which is that dub sound. This shows the start of systole, that end of diastole, and those valves closing. What we don't want to hear is an S3 or an S4. Oftentimes this can be indicative of cardiac problems as well as murmurs or rubs or things like that, which we'll talk about later in this lecture. When we are palpating, we want to palpate peripheral pulses, getting that information about temperature and kind of looking at the perforation throughout the body all the way down to those extremities. If our pump of our body, which is our heart, if that doesn't have enough blood or it's pumping ineffectively, which means it's really weak and, wimpy, then our blood's not getting down all the way to our toes and our fingers, where, gravity kind of fights it. So that's why we're checking those pulses and the temperature. We're also palpating and assessing that edema to look for swelling, and then we're checking all of our pulses as well as we go along. Some of our other diagnostic things with our objective findings would be changes in our vital signs. So this is going to be changes with our heart rate, our blood pressure, respiratory rate, because heart and lungs are tied together. We may have changes in our orthostatic blood pressure, which we've seen in the clinical setting. And then we might have changes with that widened pulse pressure, which we talked about with our increased intracranial pressure. So some of our early signs of poor perfusion that may be tied in with our cardiac system would be low urine output because that blood is not getting to those kidneys to perfuse those. Hypotension, weak pulses, altered mental status because that blood flow is not getting up to that brain. So those patients might be a little bit confused. We may also utilize diagnostic data. We're going to talk a lot about those different tests, but for the most part with our cardiac system, we're looking at electrocardiograms. This looks at the rhythm and any arrhythmias that might be occurring in the electrical conduction of our heart. We may look at chest x-rays, which may look at things like pulmonary congestion or heart size. We're going to do probably an echocardiogram. This can look at the actual valves of the heart, make sure those are functioning. It can measure what's called the ejection fraction. So this is how much blood is out at the end, how much blood their heart is putting out. And then we do things like lab testing. BNP looks at heart failure. We may look at our electrolytes, do a CBC, some lipids to look at cardiovascular health, and then troponin levels as well, which is our gold standard for some of our heart diseases or our heart disorders. So always assess your patient, get a good baseline of their cardiovascular system, and look for some of those cues that are indicative of problems in the cardiac system. Okay, so for our common diagnostic studies, I mentioned the EKG or ECG, mentioned a chest x-ray and an echocardiogram. This looks at the function of the heart, looks at the electrical impulses and the valves and the structure itself. For a stress test, this is something that's given to patients to evaluate what their heart does during physical stress or medication-induced stress. So there's two different types. There's an exercise stress test and a pharmacological stress test. The exercise stress test looks at a patient's perfusion, cardiac rhythm, those types of things while they're on a treadmill or a bike. The pharmacological one utilizes dobutamine and adenosine to kind of stress that heart out and evaluates what's going on in the heart and the electrical conduction in the heart. This helps to look at coronary artery disease and any perfusion deficits that the patient might have. For these, just the main thing with those are that the patient remains NPO 4 hours prior, just so that they don't vomit or have any problems with that. No caffeine or nicotine before the test, since that can alter the results, and to evaluate the patient for any chest pain or detrimental EKG changes while they're doing that test. For our cardiac catheterization, this is a procedure that helps visualize the coronary arteries, can help test cardiac pressures, and looks at blood flow. This is usually used to diagnose or treat blockages, so we can add stents or do angioplasty. This is also a diagnostic tool to evaluate whether the patient needs any treatment for an MI or any unstable angina. And we're going to talk about these in future slides. For our cardiac cath, the main thing is that we need to assess for allergies to shellfish or iodine, since we do utilize contrast in that procedure. Evaluate their kidney function by getting a baseline creatinine and keeping the patient NPO for 6 to 8 hours. After our procedure for our cardiac cath, depending on what site they go in, femoral versus radial, we would assess the patient for bleeding and do that post-op IV fluid. So we'll talk a little bit more about that we're looking at. For our lab functions, your troponin level is going to be the most specific lab indicator, looking at cardiac muscle decline, so myocardial infarctions. We will assess those troponin levels. What we do is we typically will take the trend of that, so we'll draw 3 different troponin levels. Typically, the level we have should be less than 0.03. And so if that elevates, typically you'll see elevation in those three blood draws. And so we'll see that occur about 4 to 6 hours after an MI. These can stay elevated up to 2 weeks. So you might have patients who come in and have an incidental finding of an elevated troponin, which can indicate that they've had some cardiac issue occur previously. For our BNP, this is our B-type natriuretic peptide. This is our lab level that we draw to indicate heart failure or look at the severity of heart failure. So for our normal BNP, it should be less than 100. If it's about 500 or more, this can signify pretty significant heart failure. We'll look at lipid panels. This measures cholesterol levels to look at risk factors for coronary artery disease. We may do things like our CKMB, which is a test that can look at cardiac dysfunction as well, although our troponin and our BNP are pretty much our gold standard for those disorders. Let's see, and I think that's it for this slide. Okay, so we are going to start talking about some EKG basics. You will be required to analyze a couple of the basic waveforms for the EKG that your patient may have or that telepack that they may be on, looking at the electrical conductivity in the heart. So I'm going to teach you some basics. You may have to be aware of how to evaluate a cardiac strip if you're given a waveform, and you have to figure out what rhythm it is. And typically this is tested on NCLEX, especially some of our waveforms that might represent a waveform that might harm your patient or kill your patient. So usually they test on those. We're going to do our basics, so we are not going to talk about heart blocks and those types of things. You'll learn more about that in our complex care. So we're going to start first with talking about our waveform basics. So this right here, this little waveform that's on your picture, indicates one full heartbeat. So this is the electrical impulse that has one heartbeat. So this is one cardiac cycle. Now we'll go over the key components of it. So when we look at our P wave, this is that first little hump there in that line. That's where your atria contracts and your atrial depolarization occurs. So this is where that electrical impulse leaves the atria and that atria contracts and pumps the blood down to the ventricles. For the PR interval, that is going to be from the start of the P wave to the start of the R complex. Okay, so you see how that's the interval. So that's that whole time frame. That PR interval is the amount of time for the impulse to be able to travel from the SA node to the AV node. And so this is where the ventricles are filling up before contracting. So that's what that indicates in that line there, that PR interval. For our QRS complex, that's that big giant jump there, that big giant mountain peak, that is your ventricular depolarization. So this is where that electrical impulses leaves that ventricle and causes those ventricles to contract. So this is your systole on the monitor. Then you have your ST segment. So this is where the S wave ends and the beginning of the T wave, that second little hump there, occurs. So that's your ST segment. So this is the segment of time where that ventricular repolarization or recharging occurs. This is where that the ventricles start to recover and rest for a minute. Our T wave is where most of that ventricular repolarization occurs, so that second hump, and this is where those ventricles relax fully, rest, and get ready to contract again. There is a U wave that can occur on some individuals' EKGs. This is often rare, but this is where those Purkinje fibers will repolarize. If you see U waves, this can be indicative of hypokalemia, especially if they are prominent U waves that are there. For our EKG intervals, it's important to know some of the normal values of time that this can occur. So for your PR interval, our normal interval between those two sections, when you measure out that time, is 0.12 to 0.20 seconds. And so that's how long it takes, 0.2 of a second for that delay to occur from that SA to the AV node. So it's very quick. These electrical impulses are so quick. For our QRS complex, this needs to be less than 0.12 seconds. So less than 0.1 of a second is how long it takes for that ventricle to contract and that depolarization to occur. For our QT interval can vary depending on the heart rate and some things that are going on, but just know for the QT interval, a prolonged or elongated or longer QT interval can mean that the patient may have arrhythmias, so dangerous arrhythmias or problems going on. So if you start to see that QT interval increase, you would want to consult the cardiac doctor. We're going to switch next to rhythm interpretation, and we're going to look at the cardiac paper that this rhythm strip or this rhythm, these little mountains and peaks are usually printed on, because that's going to show you how to measure the time frame and the amplitude of these cardiac contractions. Okay, so if you look over to the right there, you will see this red kind of graph paper and all these little numbers, and it looks pretty confusing. But for the most part, your EKG rhythms will always be on these papers because we need these little tiny boxes, and those little tiny boxes make up one larger box. And so we need that to determine time frame. So if you look here along the left side, going up and down, so your vertical lines, those are going to be your voltage. So this tells you how strong or how high of a voltage that electrical impulse has. So sometimes you'll see really tall peaks and very low valleys. This just determines the voltage of that cardiac, of the electrical impulse. Sometimes they're a little bit lower, and that's okay. That just means that heart doesn't have a high voltage, and it can just mean that maybe your leads are placed incorrectly, or there's something going on in the patient to just assess there for the cardiac provider. As you go along those the horizontal axis, you can see that there are the little tiny boxes. So each tiny small box is equivalent to 0.04 seconds. Those little tiny boxes each make up one large box, and that is 0.20 seconds. So you can see that. And then one of the 5 of the large boxes makes up 1 second. So this occurs very quickly within a second or two. These cardiac contractions and electrical impulses can occur. So when we're looking at rhythm interpretation and how to interpret an EKG strip, this is used to determine how that heart is beating and whether it's normal or abnormal. And it can indicate a lot of clinical actions that you need to do as a nurse. So our main thing, our main goal is always going to be to determine and detect life-threatening dysrhythmias. So we're going to talk about some of those. We're going to look at a normal one. We're going to look at a normal rhythm, one that's too fast, too slow, and then some of our oh no ones or our life-threatening dysrhythmias. So when you get a rhythm strip, you're going to kind of go through a step-by-step process, and we're going to break it down so that it should be a little bit easier to kind of navigate through these strips. Now, cardiac is a specialty, right? So you can go to a cardiac unit and they'll test you on your cardiac strips, and you have to recertify every single year to make sure that you're recognizing those strips. But just know it's not going to come easy. This is one of the most complex things that nurses can do, so it will take some practice. So first, your first step is going to be to determine the heart rate. And the way you do that is you want to first make sure that you're evaluating a 6-second strip. So you want to look to make sure that that strip is long enough so that you can get 6 seconds. So that's going to be at least 30 of the boxes, because remember, 5 boxes equals 1 second. So you want to make sure you get at least 6 seconds worth of time. Then what you're going to do is you're going to count those QRS complexes. So that's where that big giant mountain occurs, the tallest peak of your one heartbeat. You're going to take the tallest peak and you're going to measure the boxes in between the next tallest peak. And you're going to look at how fast your heart rate is, because remember, that big tall peak is the ventricle contracting. So you want to see between 60 to 100 of those in that 6-second strip, and not 60 to 100 of those beats, but you're going to want to see at least the correct number in that 6 seconds. And I'm going to show you how to do that, and I'm going to put a video in here as well that will help you do the 6-second strip calculation. So what you typically will do is you will take your QRS complex, so that very tall peak, you're going to find one that hits on a line that is going vertically. So one line, one of your darkest lines that's going vertically. Then you're going to count the teeny tiny boxes in between that Q peak and the next Q peak. And so you'll count how many boxes there are. So let's say we have 23 boxes in between one Q peak and the next Q peak. You're going to take that number and you're going to divide it by 1,500. So you're going to do 1,500 divided by 21, because that's the little tiny boxes in between, and that's going to give you 71. So your heart rate is 71 beats per minute. I will go over this in class because I want to show you how to do it, because it's a little hard to explain on here. But again, I'll put up a video and you guys can practice and stuff, but I will go over this again in class. But so your Q peak to your Q peak, using your 1,500 division is going to be probably the easiest way to do your rhythm interpretation for your rate. So once you evaluate your rate, let's say we're going with our 71 beats per minute, you're going to say it's either a normal heart rate or it's less than 60, which would be bradycardic or too slow, or greater than 100, which would be considered tachycardic, so too fast. Then what you're going to do is you're going to evaluate the rhythm and look at, is it regular or is it irregular? And so what we're looking for is we're going to measure the R to R interval. We want to make sure that those are even, they space out. And again, you can use a piece of paper and kind of put it underneath your waveform, mark a little line on the R, make sure the next R, you mark that down, and then make sure those space out. And I'll show you how to do that with a piece of paper in class. And again, put up a video, but it's easier once you see it. This is going to make more sense. But your evaluation of your rhythm, whether it's regular or irregular, is to look at the measurement of the R to R interval. Some of our regular rhythms, or our regular rhythm means that those spacings are equal. Some of our irregular rhythms may indicate irregular spacing of that. So one of our examples would be atrial fibrillation, and we'll talk about that. I have an example of it in this PowerPoint. Our next step is to analyze the P waves. So those P waves, that first little hump on the line, we're going to look to see, are they present? And if they're present, are they consistent with one P wave to every QRS? So remember, we should have one P wave, and then that QRS complex, that giant mountain, should follow one small mountain at the beginning. So for every P wave, there should be one QRS. Sometimes we can have inconsistencies there. Sometimes we can have missing P waves or P waves that we are not able to see because they're hidden. This can be in our atrial fibrillation or our VFib or ventricle fibrillation in those arrhythmias. We may have extra P waves, so you might see 2 P waves for every QRS, and that would be your heart blocks or your atrial flutter, which you're going to talk about in complex care. So you should have 1 P wave for every QRS, and those P waves should be upright, meaning they're a mountain, not a valley. Okay. For your PR interval, you're then going to measure the PR interval. So that's the beginning of your P wave to the start of the QRS complex. That should be 0.12 to 0.20 seconds. If not, if that's longer, that's going to indicate different blocks of the AV node and different blocks of the bifurcation there in the heart electrical impulse. And again, your heart blocks are going to be something that you're going to talk about in complex care. But essentially what this means is there's something going on in the pathway that I explained. That pathway, there's some sort of block or something that's delaying that electrical impulse from going really quickly through the heart. It delays it. It takes longer to do that. And so you'll see that waveform and the PR interval get longer. For your fifth step, you're then going to want to measure the QRS complex width. So that big giant mountain, if you see, that's a really narrow, thin mountain. That mountain shouldn't be wide because as it widens out, that's showing that that ventricle is taking longer to contract and there's a problem. So our normal QRS complex should be less than 0.12 seconds, and this indicates good ventricular contraction. Now that's our most important thing with our heart rate, is that our ventricles contract appropriately, right? Because that's what's pumping out the most blood into our body. If we don't have good ventricular contraction, then our heart starts messing up and we could code and die. So if we have a wide QRS greater than 0.12, this could mean that we have a problem with our bundle branch block. And again, that's a cardiac thing, complex care, but we're going to talk a little bit about ventricular problems. And then if it's super, super narrow and there's multiple QRSs happening, then it's a supraventricular rhythm. And if our ventricles are beating really quickly right in a row, then that's just as bad as if they're beating too slow and it's not filling up enough. And we'll talk about that when we look at SVT or supraventricular tachycardia. There's other things that our cardiac rhythm can tell us. So for our ST segment, that ST flat area from the S complex, the bottom of the S to the end of the T, if we see an elevation in that flat part, if that's an elevated higher level, then that could indicate a STEMI or a heart attack, which we're going to talk about. If it's depressed and it's lower than the baseline of the line, then that could mean ischemia, which means the patient had some muscle decay earlier. Again, for our T wave, if we have a peaked T wave or too tall of a T wave, this can indicate hyperkalemia. Excuse me. If it is flat or inverted, this can lead or indicate hypokalemia. So we're going to look at some practice rhythms, and you guys will get used to it as we go along. Again, what I'm looking for in this class is that you can do a basic rhythm interpretation. You're going to be able to indicate, is it a normal rhythm? Is it too slow, too fast, or is it an oh no rhythm? Heart blocks and like AV blocks, bundle branch blocks, those kinds of things. Some of the rhythms you're not going to learn. I'm not going to test you on them. And that will be in complex care. Make sure that you can catch some of those later. So we're just looking for the basics right now. And again, I'm going to put in a video and we're going to talk about this in class again. Okay, so before I teach you abnormal, we got to go over normal. So our normal heart rate or rhythm is called sinus rhythm. So this is because the heart's electrical impulse is originating from that SA or sinoatrial node, and that's that neutral or natural pacemaker of the heart. So this is our normal beating, normal organized pattern of electrical impulse. So for it to be considered sinus, it has to meet a couple of things. So it has to have that normal heart rate between 60 to 100 beats per minute. That regular R to R interval has to be there. So there's consistency in that. It marches out. Those P waves or that first hump looks the same. There's one P for every QRS, and those P waves are upright. So it's a nice, smooth looking hill. The PR interval is 0.12 to 0.20 seconds. So it's got that normal length of contraction. And then we have our QRS complex. Our QRS complex is that big P, that big peaked mountain, and that's less than 0.12 seconds. So if it meets all of that criteria, chances are it's a normal sinus rhythm. And so if you look here on the picture, if you're looking and going along, you can see one P wave. Now these P waves aren't as smooth, they're a little more pitched, but that's okay. They're present. They have the good timing of them, so they're marching out evenly, and they follow or precede a QRS complex. And those QRS complex are less than 12, so they're nice and narrow, nice and tight, and they march out evenly. So the space in between the peak wave and the peak wave, they're the same distance. So if you measured, if you took a ruler or a piece of paper and you held it up to those peaks, they would be even, and the next set of peaks would be the same distance and the same distance and the same distance. So that means that heart rate is beating the same. It's regular, that pattern. You can almost, like march it out like you would in a song. So for that sinus rhythm, this indicates a normal, healthy heartbeat. It shows that there's good cardiac output and that perfusion, and that we don't have to do anything as the nurse. We get to just go have a coffee, go hang out at the nursing station, and we just get to have a great time. Okay. When we look at our sinus brady versus our sinus tach, this is where they're going to have the same components of that rhythm, but they're going to be either slower or faster. And so we'll talk about that on the next couple slides. So when we look at arrhythmias or dysrhythmias, both of these are synonymous with each other. This is an abnormal heart rhythm, and this can be caused by a problem with the electrical conduction of the heart, so those nervous or electrical impulses, or it can be caused from different abnormalities in the body, like too much potassium, too little potassium, different metabolic issues, those kinds of things. And we'll talk about that as we go along. These rhythms might be too fast, too slow, or just irregular. And so this is going to affect how well the heart is pumping and how much blood is going to be able to go through the body and through the lungs and to the brain and things like that. So we'll look at different arrhythmias and try to figure out how to assess them. For our patients with arrhythmias, these may be where you get up off the nursing station chair and you go assess your patient. You might have to do some stuff with them. Some arrhythmias people live with, and we'll talk about that. But some arrhythmias can lead to cardiac arrest, and then you really got to run. You put your coffee down, run, call the doctor, you start screaming. all that good stuff. So we'll talk about a little bit of the arrhythmias that I would like you to know and that are very important to know. So too slow, too fast, and oh no are going to be your arrhythmias to know for your exam. Okay, so we're going to talk about sinus bradycardia. So this is our too slow arrhythmia. So Brady means slow, low and slow. This heart rhythm originates from the SA node, so it is sinus, it's originating from the correct area of the heart, but the rate is too slow, so it's slower than normal. This is defined as a rate less than 60 beats per minute. Now, when you're looking at those cardiac strips, remember, you got to make sure it's a 6-second strip or else it'll throw your count off. So don't be thrown by that. I know some of the hospitals will test that and they won't give you a full 6-second strip. And so it looks like a normal sinus rhythm, but it's actually sinus Brady. Now with our sinus Brady, this is still a sinus rhythm because it starts in that SA node, but those ventricular contractions are slower. So those QRS complexes are wider. So there's more of a distance in between those big, tall mountains, right? You can measure it, measure the time in between. And so that's longer. There still is one P wave for every Q wave, and there's still those T waves as well. So there's all of the parts of the beat is there. So that's not the problem. It's just that it's going too slow. Usually, this occurs because we have medications that slow our heart rates. We may have an increase in our ICP, but a lot of times we see sinus bradycardia in people that are just physically fit. So our heart doesn't have to work as hard because we're used to that athletic conditioning of the body. So some people just have a naturally low resting heart rate. So they're bradycardic, and that's okay, as long as they're not symptomatic. So we worry when we see that the patient's acting funny or they're having problems from not enough blood flow. And usually what we'll see is that they'll be dizzy, they'll have level of consciousness changes, and they might have some hypotension. And that's because that heart's not beating enough to get the blood up to their brain. So that's causing a lot of problems. With our patients who are athletes or they're normal with this sinus bradycardia, they're going to be fine. You're going to assess them. They're not going to have any dizziness. They're going to be alert and oriented. And they're probably just going to tell you, yeah, that's a normal for me. My heart rate is usually low. For our symptomatic patients with bradycardia, sinus bradycardia, what we're going to want to do is we're going to make sure that we assess them first, make sure the patient matches the reading. So don't just trust the monitor, assess the patient. And then we may need to give them some medication. So the medication for bradycardia is atropine. This helps with the contraction of the heart, so it beats harder and can actually help with that rate. Other things we may do, excuse me, is transcutaneous pacing. So that's where we will put the little sticky pads on the patient and we're actually going to pace them electronically. So that gives an electrical stimulation to the heart and helps it beat effectively. So it increases the rate of that heart rate. If it's medication occurred, maybe we gave them a beta blocker and we went, oops, now they're not beating fast enough, then we're going to hold that medication and consult cardiology. Okay, so if it's going too slow and they're symptomatic, we want to increase the rate of their heart. If it's going too slow and they're not symptomatic, we're going to assess them and say, is this your normal? And then we're going to go grab our coffee and go sit down and have some fun at the nursing station, chit chat, whatever, if it's normal. Okay. Okay, now we have our too fast. So we've got our sinus tachycardia. So sinus means it originates from the SA node. Tachycardia, tachy, means it's too fast. So for our patients with sinus tachycardia, this is typically a heart rate greater than 100 beats per minute, up to 160. Because if we go a lot higher than 160, it's something else entirely, and we're going to talk about that. So between 100 to 160 is sinus tachycardia. They have those R to R intervals that are regular. Those QRS complexes have a P wave with them. So everything is equal, but that distance between the two mountains is going to be less. So there's less time in between. So that means our heart rate is faster. This means that those ventricles, the bottom of the heart, is contracting faster. Now, if our heart at the bottom contracts faster, that means there's less of that relaxation time that helps to fill up the bottom of the heart with blood. So, if our heart is beating too fast, it can lead to a reduction in our stroke volume and our cardiac output, which is not a good thing. We want a good amount of blood to go out of our heart into our lungs and into our body. So we don't want our heart to beat too fast, especially if we are symptomatic. So again, we're going to assess our patient. So look at the monitor, see sinus tachycardia, say, yep, that's tacky. Let me put down my coffee. I'm going to go assess my patient. If your patient is symptomatic, they may again have hypotension, dizziness, loss of consciousness changes, and this is because the ventricles are not able to fill up with enough blood so that even though that heart is pumping quickly, it's just shooting a bunch of nothing up into our brain, into our lungs, and into our body. So we're going to have to see a decrease of that perfusion. Our patients may also say that they're feeling kind of funky, right? They're going to feel anxious. They may have their heart may be beating out of their chest, so they may be a little bit nervous. Now, for our causes of sinus tach, oftentimes we see this with patients who are dehydrated, especially here in Arizona, because we don't have enough volume. So the volume in the tank isn't there in the heart. The volume in the tank is not there. So our heart increases its heart rate to compensate for that. So you'll see that in dehydrated patients. We will have a short-lived tachycardia if we get scared, right? If somebody says, "Oh, you have a test today that you didn't study for," your heart rate's going to beat a little bit faster, right? Because you're anxious or you're stressed. It can occur with fever, pain, infection, those types of things. It can occur from a problem with the respiratory system because heart and lungs are tied together. So if your patient has hypoxia or pulmonary embolism or something like that, your heart's going to increase its rate to compensate for the lack of oxygenation throughout the blood. It can occur from our stimulants like drugs, caffeine, our monster drinks, caffeine pills, those types of things, and it can be from a medication effect as well. So for our management of sinus tachycardia, you want to assess your patient. Are they symptomatic? Are they not symptomatic? Sometimes we can tolerate a little bit high of a heart rate, right? Maybe I'm 110 and maybe it's just because I got done walking up the stairs and my body will come back down to normal. Or maybe I'm just a little sick and I've got a fever and that's just my body's way of compensating and trying to get rid of the infectious agent. If our patient is symptomatic, then we may need to do something about it. So for our patients, one thing to slow that heart rate down that we can do is we can give some medications like a beta blocker. That's usually our first response. Maybe give them a little metoprolol to slow that rate down. We can give them a little calcium channel blocker like diltiazem or cardizem that can slow that rate down. We can treat that underlying cause, like give them a bolus of fluid if they're dehydrated, give them Tylenol if they've got a fever, figure out how to reduce that anxiety or that pain. So that will usually take care of that. For our sinus tach, remember this is not something that's treated with cardioversion. We're going to talk about what that is, but just remember sinus tach is kind of a normal abnormal. So if your patient's symptomatic, treat the symptoms, but don't go bringing out the shocker machine. Okay, so we're going to talk about that, what cardioversion is in a later slide. Okay, so now we're going to talk about our first oh no rhythm. This is called supraventricular tachycardia or SVT. This is a rapid heart rhythm that starts above the ventricles, usually in the atria or the AV node, and causes the heart to beat very fast and inefficiently because it doesn't have enough time for those ventricles to adequately fill up with blood. So we have an increase or a decrease in cardiac output. For our SVT, our heart rate is usually between 160 to 250 beats per minute. The rhythm is still regular, meaning it still has the P wave, the QRS complex, and the T wave. But what you'll find is that the ventricles are beating so quickly that the QRS complex actually hides the P wave. So those are oftentimes hidden. Our QRS complex is still narrow, so less than 12, less than 0.12. But that PR interval is oftentimes hard to measure or very narrow together. So the distance between the QRS complex is really close together. So that's showing that there's that abnormal electrical current that stimulates the heart and stimulates those ventricles to contract too rapidly. So this reduces that stroke volume and reduces cardiac output. So for our patients with SVT, they are going to usually be symptomatic. They're going to feel those palpitations or that fluttering in their chest. They're going to get very dizzy. They're going to have some chest pressure or anxiety. And so we've got to slow this heart rate down. So our first thing we do for SVT is we do a vagal maneuver. So this helps to stimulate that vagal nerve. It helps to slow down the heart rate by impacting that parasympathetic nervous system. So by causing the vagal nerve to be stimulated, it helps to slow down the heart rate. So you can have your patient bear down like they're going to have a bowel movement and hold down. They can cough repeatedly, hard coughs, or they can blow through a straw or blow into a syringe. So they'll blow on the end of the syringe and tell them to blow so hard that they're trying to push the plunger out with their air. And because that creates that pressure of that vagal stimulation, that's going to help slow that SVT down. Now, we only do this for a brief moment. We try to do those vagal maneuvers. If that does not work within a couple seconds, they're about 30 seconds to maybe a minute, we then will do medications. So we want to do adenosine. That's going to be rapid IV push because adenosine stops that heart momentarily. You're going to see a loss of heart beats. And then that should restart the heart and help to reset that rhythm. So adenosine is usually given with it's called a stopcock, and it's a rapid IV push. And because that adenosine has a short half-life where it doesn't last very long, you'll want to push it using that special attachment. And you'll see that in complex care as well. But that adenosine puts the brakes on that heart, stops that heart for just a couple seconds, and then resets that rhythm, and that AV node or the SA node is able to take over and have that intrinsic rate again. We also can do what's called synchronized cardioversion. So synchronized cardioversion is a defibrillation of that heart current. So we do shock the patient, but what it is it's a lower volume of shock and it occurs on the QRS complex. So that patient will be shocked. This is only if they're unstable because cardioverting can cause them to throw a blood clot or can cause a clot to kind of just become dislodged. So they don't have time to do any anticoagulation prior to cardioverting the patient. So synchronized cardioversion is for patients who are unstable, meaning they are severely level of conscious changes, confused, their heart rate is super, super high, they're dizzy, they're passing out or having syncopal episodes. Let's see, for your, I think anything else? I think that's it for this. Oh, for your causes for SVT, again, this can spontaneously occur, but it can be caused from things that kind of push that rhythm into being abnormal. So things like medications, alcohol, or caffeine, especially tied with dehydration, emotional distress, or things like that. But it can spontaneously occur in patients. And a lot of times this is the rhythm that will bring patients in because they have a syncopal episode, and then they feel their heart racing and then they pass out, or they pass out, they wake up, their heart's racing, those types of things. So you'll see that a lot with patients who have passed out or had a syncopal episode. Okay, so we're going to talk about another little oh no rhythm. Now, this one is a mild oh no because some people can live with atrial fibrillation, especially if the ventricular rate is controlled. But if there's a rapid ventricular rate, then we would want to change or intervene on the patient. So, atrial fibrillation is an irregular heart rhythm where that atria or the top of the heart quivers like jello instead of contracting and squeezing effectively. So the SA node does not control the rhythm. There's multiple chaotic electrical impulses from different areas of that atria that kind of cause that atria to fibrillate. So it's kind of like a seizure almost for the top part of the heart. There's all those electrical impulses happening all over the place. And so this leads to an irregular ventricular response because the ventricle down there either does what it's supposed to, and that's beats normally, and so that's what you'll see with a controlled ventricular rate or CVR, or that ventricular goes, what is happening? I guess I better beat whenever my atria fires, and so I'm beating here, I'm not beating here, I'm beating, I'm beating, I'm beating, and so it rapid fires and causes a rapid ventricular rate or RVR. And so the thing we worry the most about with this atrial fibrillation is what occurs in the top part of the heart, in the atria, when the heart is sitting there quivering. So if that atria is not pumping and not contracting effectively, then there's blood that's pooling up in the top of the heart. And when blood pools, it can start to coagulate, and so blood clots can occur. And so what we worry about is once the heart in the atrium does end up contracting, then that blood clot can actually go down into the ventricle, which then can be contracted because that ventricle is either doing normal contractions or it's doing too fast of a contraction, that blood clot can then be pushed out into the body. And so what they have is then an increase for clots like DVTs, pulmonary embolisms, or a stroke. And we talked about that in neuro. So atrial fibrillation is a risk factor for blood clots and stroke. So we really want to make sure that we control the patient's heart rate. Now, I said some people live with AFib, especially our geriatrics patients. They oftentimes will have AFib, and that's okay because their atria is acting a little funny, but that ventricle is contracting at a normal rate. So they have the blood flow, they have the normal cardiac output and perfusion, and so we don't worry about that. But when that ventricle is going too fast, we worry because, again, that ventricle is not refilling with blood, and so we're losing our cardiac output. So we really want to assess our patient and see what that rate is. So for your atrial fibrillation, again, it's going to be irregularly irregular, which means the QRS complex can be uh, predictable, so it can beat out or march out together, but your P wave will be chaotic. So the P waves are not going to be there because that atria is not fully contracting. What you're going to see is a chaotic line. So if you kind of look at the strip here that I gave you, you see how it's kind of a waving like squiggly line, and then you have your big tall mountain. So your squiggly lines is that atria sitting there shaking like jello instead of that nice strong contraction. Now, every once in a while, you can get the atria where it will beat effectively, but for the most part, that atria is just sitting there fibrillating. That ventricle does what it's going to do and it will beat effectively. Now, some of those QRS complexes are marched out, meaning they're equal in between the peak to peak, that distance in between is equal, and some of them are a little bit closer. So that's because that ventricle is not really sure what's going on, so it's just kind of beating a little funky monkey. So your patients with this, so your patients again with fifth atrial fibrillation, our management is going to be to give them medications for rate control and rhythm control. So for rate control, we'll probably get them on dialtalazine or metoprolol to get that rate a little bit more controlled. We want to do some rhythm control, so things like amiodarone or a synchronized cardioversion, especially if your patient is a little bit symptomatic, we can do that cardioversion. For the most part, that atrial fibrillation will be cardioverted after the patient is anticoagulated because we worry that there's a blood clot sitting there waiting to go in a bad area of the body. So that's why we want to anticoagulate them before we do a cardioversion. So for our anticoagulation, we're going to give them warfarin or apixaban, and those medications will help to do some anticoagulations in that blood so that hopefully there's no clots that are going to get thrown to other parts of the body when we do a cardioversion. We also want to fix the cause. So if it's an electrolyte imbalance, if we have problems with medications, if we have heart failure or anything like that, that's the cause of this, then we would want to fix that problem as well so that we don't continue to have this happening. Okay, so now we have our big mama jamma. Oh no. So this is a lethal rhythm. So this means if you see this on your patient's monitor, you're grabbing the code card and you're starting compressions. This is called ventricular fibrillation. So instead of our atrium fibrillating like jello, we now have our ventricle fibrillating like jello. So that ventricle is not contracting fully and it's not contracting in a regular rate. So that ventricles are quivering and they're not filling up with blood. There's no coordinated electrical activity, and so this patient will have no cardiac output and oftentimes no pulse. So we would require emergency intervention. Most of the time, your patient loses consciousness, they collapse. This is where you're walking down the hall and you see somebody fall on the floor, check a pulse. They don't have a pulse, and you are starting CPR. So for our patients, we're going to put them on the monitor, going to see this squiggly line. These are your QRS complexes that are just chaotic and they're not filling up with blood, and so that electrical impulse is not occurring. This rhythm right here is a shockable rhythm, so you are immediately going to defibrillate the patient. And then after 2 full rounds of CPR, you can start the ACLS medications or your cardiac medications to bring them back. But your main thing is to check a pulse, start CPR, defibrillate them fully. Now, defibrillation is different from cardioversion. Defibrillation is full electricity and it is going to shock immediately. It's not going to wait to try to find a QRS complex to shock on. So if it did, it would just be shocking randomly. So remember, when we shock our patient who's in ventricular fibrillation, it's called defibrillation. And this is going to shock them immediately. So clear yourself away from the bed so you don't get shocked yourself. These patients will get medications as well. So this would be your epinephrine and your amiodarone. These help to dilate, vasodilate, help with rate control, and help to get that patient back to normal rhythm. So between shocking and medications, hopefully we get a pulse back and it's some sort of organized rhythm that that patient will get. But this is your big, giant lethal rhythm. So if you see this, start CPR. Okay, so this is another oh no rhythm. This is what I call the sneaky oh no rhythm, because on your monitor, your patient will have a regular looking rhythm. There's a P wave, a QRS complex, and a T wave, but the patient has no pulse. So you walk in, your patient's not responding to you. You look at the monitor, there's a normal rhythm. You check a pulse, there's no pulse. So your patient is technically dead. It's a form of cardiac arrest. So this is another lethal rhythm that you need to pay attention to. For our PEA, or pulseless electrical activity, you will start CPR immediately and you will call in the code team. Most of the time, our causes of PEA are your H's and T's. So these are things like hypovolemia, hypoxia, hydrogen ion excess, which is your acidosis, hypo or hyperkalemia, hypothermia. Your T's are going to be a tension pneumothorax, cardiac tamponade, which you'll learn about in complex care, toxins, thrombosis, which occurs in either the heart, like an MI, or in the pulmonary lungs, which is a pulmonary embolism. Your patient will be unresponsive, no pulse, not breathing, but that monitor is still going to show an electrical rhythm. So priority action is to start high quality CPR. This is a medication only, so we give epinephrine and try to medicate that patient. Defibrillation is used for our VFib or our pulseless VTAC. Okay, and now we're going to talk about our final oh no rhythm. This is called asystole. So asystole is a total absence of electrical activity within that heart. So that heart is not contracting at all. There's no cardiac output and your patient will not have a pulse. So this is your complete cardiac arrest. So this is your oh no lethal rhythm. For this patient, because the heart has completely lost all electrical activity, the only thing we can do is start high quality CPR and do our medication. So epinephrine every 3 to 5 minutes. We're going to try to try to reverse those causes of those H's and T's and try to do high quality CPR. If we get a rhythm back, one of those shockable rhythms, we can then put shocking in. But this asystole as its own, if you see this on the monitor, this is not a shockable rhythm. So we can only do CPR and get epinephrine. Okay, so we're done with our rhythm interpretation. Now, sometimes our patients, like patients with bradycardia, or patients that have had any type of ventricular fibrillation or anything like that, where we've gotten their rhythm back, they may require the use of an implanted device. So there's two different devices we're going to talk about. There is a pacemaker and there is an ICD. So a pacemaker is a small electrical device that they put inside the patient's chest cavity, or inside kind of in between their skin and their muscle area. And it helps to slow and control irregular heart rhythms. So it helps by sending electrical impulses, and it stimulates the heart to contract when needed. So pacemakers are usually used when the patient is too slow or when it has impaired conduction. So sinus brady or patients with heart blocks will usually get pacemaker. Some of the things that you need to know for pacemaker nursing interventions is that you will want to assess the pacemaker to make sure that it's working, and you'll see that it's working on the EKG rhythm. You'll see big, tall spikes, and that you can see that in the picture down below. Those big, tall spikes are when the pacer has fired. So you want to assess your patient, make sure that they have good perfusion, make sure their heart rate's effectively pumping, make sure that they don't have any symptoms of dizziness or syncope or anything like that. For your patients who have had a pacemaker inserted, you're going to do things like monitor that site for infection, avoid lifting their arm above their shoulder for about 2 to 4 weeks so that those pacer wires don't get dislodged. They should avoid lifting anything heavily while they are healing. no contact sports or putting excessive pressure on that device, and then let them know that they should avoid magnetic fields like an MRI unless they've used an MRI safe pacemaker. They should carry a little pacemaker card so people know that they have that implanted device, and just make sure that you assess them on how to care for that after they go home. For our ICD, our implantable cardioverter defibrillator, so this is basically our shocker machine in a small little tiny form that the patient can have for life. So an ICD will help to continuously monitor the heart rhythm, and it will shock the patient if they have one of those life-threatening arrhythmias like VTAC or VFib. Some ICDs are a dual ICD, which means they can be an ICD and a pacemaker. So it's always important to ask your patient what kind they have. So for our ICD patients, this helps to prevent that sudden cardiac death and is often used for patients with any history of VFib or pulseless VTAC, or if they've had full cardiac arrest. Some patients with a low ejection fraction of at least 35% may get this. It helps with severe cardiomyopathy and things like that. Educate your patient that they may feel a shock, kind of like a sudden strong kick in the chest. And oftentimes this occurs without warning because your patient's not going to know that they're in a shockable rhythm. If the shock occurs once and the patient feels okay, they would notify their doctor and call their normal doctor or their cardiologist and follow their recommendations. If multiple shocks occur, then they would want to call 911 since that heart may be going into a shockable rhythm multiple times. They would want to not drive until cleared by the provider. And so these are some of the NCLEX tested things for implantable devices. If your patient collapses or you have any problems and they have a pacemaker or an ICD, you still would go ahead and do that CPR immediately. You can still defibrillate them with an external defibrillator. Those defibrillator pads can go over the device, but you'll want to kind of offset it as much as possible. Okay, so we're going to talk about angina pectoris. This is a fancy word for chest pain or discomfort that occurs when that heart muscle doesn't get enough oxygen-rich blood. So it's usually caused by reduced blood flow due to problems with the coronary arteries, through coronary artery disease or arteriosclerosis, which we're going to talk about later. When our coronary arteries narrow because of that plaque buildup or spasms, blood flow to that myocardium is not enough, and so that myocardium starts to become ischemic, and that ischemia causes chest pain or pressure. If they have prolonged ischemia, then that can progress to a myocardial infarction. So we'll talk a little bit about the two different types of angina. So we have stable angina and unstable angina. So stable angina is a predictable, consistent pattern of pain, and this can be just some like chest pain that you might feel for a minute and then it goes away. Usually this is relieved by rest or by nitroglycerin medication, which nitroglycerin is a medication that helps to vasodilate those arteries and the coronary arteries, so that blood flow can flow through a little bit easier. For your unstable angina, this would be pain that's new or worsening and usually will occur even when the patient is resting. This is what's not relieved by rest or nitroglycerin, and so we would want to call 911 if there's chest pain that's not relieved by rest or medications. So again, symptoms of that angina could be chest pain or pressure. It might be described as somebody squeezing or sitting on your chest. It may radiate down the left arm into the jaw, the neck, the shoulder, or the back area. Some patients may talk about it going into their jaw and them having a little bit of nausea or abdominal, like GI upset, Oftentimes this occurs in women, so women present a little bit differently than just the typical elephant sitting on their chest. They have that left arm pain, jaw pain, and then nausea or vomiting. Patients may be short of breath, they may be diaphoretic, or they may have fatigue or anxiety. For our diagnosis, typically what we'll do is we will administer nitroglycerin. Patients should get nitroglycerin either, usually outpatient, they do it as tablets, so little tiny pills that they put sublingually. We're going to take one tablet every 5 minutes for 3 times. If after the third nitroglycerin pill, if that chest pain does not resolve, we would educate the patient to call 911. In the hospital, if that patient is brought in with that angina or chest pain, what we'll do is those diagnostic tools. So we'll do an EKG, looking for ST depression or ST elevation, looking for troponin changes. We might do a stress test, an echocardiogram, or do a cath to look at the coronary arteries with contrast. Some of our immediate treatment priorities are going to be to assess oxygenation. If they don't need oxygen, we cannot give the oxygen, but if they do need oxygen, then you would place oxygen on first. We then would give that nitroglycerin, making sure that we look for increased perfusion and give that so that it helps to vasodilate those coronary arteries. If your patient has continued pain after the nitroglycerin, you can give morphine. This can help to relieve that pain and does help reduce that workload a little bit. It used to be that we used the acronym MONA, but that's kind of outdated now. So morphine and oxygen are only given if it's needed and indicated in the patient. We would for sure want to give aspirin. So aspirin is given as a platelet aggregator so that hopefully there's no buildup of blood in that vessel that's narrowed or closed down. For your patients, again, let me just go over nitroglycerin teaching. Take one tablet every 5 minutes, up to 3 doses. If not relieved, call 911. Make sure to educate the patient that headaches or flushing is a normal expected outcome of nitroglycerin because it vasodilates everything, and so patients oftentimes get a headache. They should sit down before taking that medication. That'll help prevent any hypotension, dizziness, passing out, but make sure that they take that nitroglycerin and call 911 if it's not relieved. Coronary artery disease is the most common cardiovascular disease and occurs when those coronary arteries become narrowed or blocked due to arteriosclerosis. So a buildup of plaque in those arteries or a narrowing of those arteries. This results in a restriction of blood flow and oxygen, leading to that heart muscle, and so that ischemia, that angina can occur, and it can lead to a myocardial infarction. For our patients with coronary artery disease, it's important to understand risk factors. So there are modifiable and non-modifiable, and we want to educate our patient on those risk factors. For our non-modifiable, it's going to be the same as most cardiac things. Age, coronary artery disease risk increases with age. Gender, men are at an earlier risk for coronary artery disease. If you have any history or family genetics of it, and then African Americans have a higher prevalence of it, so ethnicity is a non-modifiable risk factor. For our modifiable risk factors, we have smoking and nicotine use, hypertension, hyperlipidemia, diabetes, poor diet, inactivity, stress, and obesity. So all those things we should be able to change. Coronary artery disease can be asymptomatic, meaning they don't know they have it for years, and then all of a sudden it can present as different problems with the coronary artery system or the cardiac system. So they can have angina pectoris, which is that chest pain with exertion or stress, shortness of breath, palpitations, They can have symptoms of that MI, so chest pain that doesn't go away with rest and nitro. They can have diaphoresis, nausea, or in women, that back pain, jaw pain, nausea, vomiting, indigestion feeling. For our patients with coronary artery disease, oftentimes they will do echocardiograms, cardiac cath to look at blockages. They'll do lab levels for troponin and lipids. They may do a stress test, or they may look at EKG changes. For our treatment and management, we will want to modify the modifiable risk factors, start them on some medications. So we'll probably put them on an aspirin, which helps prevent clot formation, beta blockers, which can decrease the heart rate and decrease the workload on the heart, calcium channel blockers, which can help with vasodilation, those nitrates that'll help relieve chest pain, statins that help lower cholesterol levels, your LDL cholesterol levels, and then ACE inhibitors or ARBs that can help improve cardiac remodeling and blood pressure. If we find that those coronary arteries are blocked, they can do what's called PCI, or percutaneous coronary intervention, which we'll talk about, or they can do a CABG, or a coronary artery bypass graft. So we'll talk about both of those. But it's just important to kind of understand what coronary artery disease is and how to educate on that for your patients. We are going to briefly touch on ACS, or acute coronary syndrome. You will go over this a lot in complex care as well, but we'll touch base on it, and you'll kind of need to know the difference in interventions that you would do as a nurse. For acute coronary syndrome, it's an umbrella term used to describe any conditions that cause reduced blood flow to the heart. It can be from a rupture of arteriosclerotic plaque, or a clot formation in that coronary artery. It does include unstable angina, non-STEMI or NSTEMI, which is a non-ST elevation myocardial infarction. So basically what that means is they are having a myocardial infarction, and there is no ST elevation on that EKG. Or a STEMI. This is a ST elevation myocardial infarction. So this is where they're having a heart attack, and you would see that ST elevation. All three of these represents medical emergencies, and we need rapid recognition and treatment. So we'll go a little bit about those. So for your unstable angina, this is that chest pain that happens even though they're resting and taking that nitroglycerin. Your troponin levels oftentimes are normal, but it could be a precursor to a possible MI happening. For your NSTEMI, you may see ST depression or T wave inversion on that EKG. This oftentimes is a partial coronary occlusion, and so this would be a treat urgently situation. That patient probably would be taken to the cath lab. They would balloon them open or place a stent to kind of open up that coronary artery. For our STEMI patients, this is an immediate emergency. This means that there is an ST elevation on the EKG, and that indicates complete coronary artery occlusion. So this patient needs immediate reperfusion, so they need thrombolytics, or they need percutaneous like a thrombus removal or a stent placement. So your percutaneous coronary intervention. For your patients with suspected ACS, again, we would assess the patient. This would be where your oxygen and your morphine would come into play, along with your nitroglycerin for vasodilation, aspirin for that antiplatelet to prevent clots, and beta blockers to help reduce that heart rate and oxygen demand. For your STEMI patients, STEMIs must get taken to the cath lab for PCI, or percutaneous intervention, within 90 minutes. So that's a door to cath lab time of 90 minutes. If a PCI is unavailable, they will do thrombolytics within 30 minutes of arrival. Okay, so we're going to go a little more in depth on PCI, or percutaneous coronary intervention. This is a procedure that's used to open blocked or narrowed cardiac or coronary arteries, helps to restore that blood flow to the heart muscle, and usually it's called coronary angioplasty, a heart cath, or getting taken to the cath lab. This can include placing a stent or using a balloon to open up that coronary artery, as you can see there in the picture. PCI is the preferred treatment again for those patients having an ST elevated myocardial infarction, or STEMI. So 90 minutes from door to PCI is the goal. This helps to restore perfusion to that ischemic heart muscle, helps relieve chest pain, can reduce the infarction size or the size of that tissue that's dead, and can help to prevent future blockage. So typically what happens is a catheter is inserted into the artery. They can either go into the femoral artery in the groin or in the radial artery in the wrist. So it just depends on which route your doctor wants to do. They guide a kind of guide wire and camera through the blood vessels to those coronary arteries. Contrast dye is then injected to visualize the blockage. A balloon can be inflated to open the artery, and then that stent can be placed to keep the artery open. For our patients, you're going to do the same thing for pre as you would surgeries. So consent, keep them NPO, check allergies to iodine or shellfish because they're going to be using that contrast. They would need to have BUN and creatinine checked for kidney function and coagulation levels checked to make sure that they're not a bleeding risk. Do IV access for medications and fluids, and then watch EKG for any cardiac changes. Post-procedure care, because they've gone in through an artery, they are at increased risk for bleeding. So that site where they go in and go in through the artery can actually start to bleed out because that artery is under such high pressure that the little dressing and the scab that they've created can actually burst open. So you want to avoid your patient bending their leg, especially if they've gotten a femoral angiogram. You would want to avoid them bending their knees, coughing or sneezing too heavily without holding pressure in the groin area, bending their head up, which can cause pressure in their cardiovascular system. So you would monitor that site for bleeding. We always want to check the pulses that are distal to the site of that puncture to make sure that the blood flow and perfusion is appropriate. Monitor for any chest pain. If your patient just had a heart cath and they start complaining of chest pain again, it could mean that they have a re-occlusion or another occlusion of a different area. So you would want to notify the doctor. If they have that femoral access, you would want to strict bed rest, keep their legs straight, don't have them move around. You want to encourage fluids, maybe hang a bag of fluids to flush the dye out to help protect those kidneys, and just monitor their cardiac function to look for any dysrhythmias. If they go in radial access, this is usually a quicker recovery. They can get up and walk, they can move around. That limb, the hand, they can't use it during that time, but for the most part, it's a little bit easier of an access. They will have what looks like an armband around their wrist, and it has air in it that's holding pressure on that artery area. Same complications to watch for, so bleeding, loss of circulation in the limb, arrhythmias, chest pain from reocclusion, any contrast-related kidney injury, reaction to that dye, or any stroke from a clot. Myocardial infarction, so we're going to talk about that. So that is also known as a heart attack. This occurs when the blood flow through a coronary artery is completely or severely blocked, and it leads to that ischemia or death or necrosis of the heart muscle. Unlike that angina, it can cause permanent damage to the heart muscle itself. There are two different types of MI. There's the STEMI and the non-STEMI. So again, ST elevation means that there's the complete occlusion of the coronary artery. ST depression or inversion can mean that there's partial occlusion. For your patients, they're going to have that signs and symptoms of cardiac problems, which is usually chest pain or pressure, radiating to the arm, the jaw, the neck, and the back. Could have nausea, vomiting, diaphoresis. They usually will have a feeling of impending doom or anxiety, and may have weakness or fatigue. For these patients, we are going to do an EKG looking for ST elevation or depression. They're going to do some labs, specifically those troponin levels, those 3 troponins, looking for a rise over 4 to 6 hours. They may do an echocardiogram looking at wall motion or ejection fraction of that heart, and then they probably will be taken to the cath lab. So for our patients coming in with chest pain, they usually will get an EKG within 10 minutes of arrival. So that's pretty standard for that. Again, we're going to do our emergency treatment, assess our patient. If they need oxygen, we're going to put oxygen on. If they need morphine because that nitroglycerin is not working for that pain, we're going to give them morphine. Other than that, we're going to do nitroglycerin, aspirin, a beta blocker, and some sort of thrombolytics and get them in to the reperfusion therapy. So a stent placement, 90 minutes door to balloon time. If not, TPA within 30 minutes. For our patients that have had an MI, they will be given antiplatelets like aspirin or clopidogrel. They'll be given statins to help reduce plaque progression, beta blockers, ACE inhibitors for rate control, and then do lifestyle modifications. For our complications of an MI, patients can have those lethal arrhythmias like VFib or VTAC. This is the most common cause of death after an MI occurs. They can also have heart failure, cardiogenic shock, which we'll talk about in complex care, or pericarditis. You'll talk about that. We'll talk a little bit about this in this class. Some of your patients that have decreased blood flow to the heart, especially if they have blocked coronary arteries, will be given what's called a coronary artery bypass graft, or CABG is what it's most commonly called. This is where a blood vessel graft is taken from another part of the body, usually in the leg, in the inner thigh, and it's used to create a pathway for blood to be able to reach the myocardium. This helps restore that adequate perfusion to the heart muscle, can decrease angina, can prevent myocardial infarctions, and helps prevent that overall heart function. So for this is a surgical procedure. They are placed under general anesthesia. They have their chest open through the sternum. So you'll see there's an incision made, and they retract and open the sternum so they can view the heart. They harvest that graft from the arm or the leg. I usually see it in the upper thigh area. This is attached to where the blockage is at, and blood is then rerouted to the myocardium. They can have multiple vessels or multiple areas. So oftentimes they'll say it's a 4-vessel CABG, 2-vessel CABG, and it just depends on how many blockages are there. CABGs are recommended when there are multiple blockages. If there are patients who have had PCI, that percutaneous intervention, and it failed, or they had a re-occlusion or restenosis of that, or if they have severe coronary artery disease. For your pre-op, again, we're going to do our normal pre-op stuff, get a consent, do your baseline labs, NPO, educate on what to expect after. For your post-op nursing care for a CABG, these patients will go to ICU for close monitoring. Believe it or not, early ambulation is going to be key. So early ambulation, getting them up, incentive spirometer to prevent atelectasis and pneumonia. We're going to monitor for bleeding, so changes in level of consciousness, make sure your perfusion is appropriate, so cap refill, skin temperature, all that good stuff. These patients may have a chest tube, so they're going to have about 150 mLs per hour immediately after that may drain. We want to monitor those chest tubes. So remember, watch for bubbling and those types of things where it's not supposed to be. Monitor fluid and electrolytes because we have risk for fluid and electrolyte imbalances. Assess neurological status because they're at risk for stroke, and then monitor for infection at those incision sites. For your possible complications, AFib is one of your most common CABG-related arrhythmias, so monitor your heart rhythm for that atrial fibrillation, but monitor for bleeding. Look for changes in heart sounds, any signs of infection, reduced perfusion. They're at risk for strokes, kidney injuries because of the contrast dye that's used, and they are at risk for respiratory complications because the heart and lungs are tied in together. After a CABG, medications that are commonly administered are going to be aspirin or antiplatelets, so that helps prevent thrombus or blood clot formation on that graft site. Beta blockers, which help reduce the workload. Statins, which help to decrease plaque. Pain management is a big one because they just had their chest broken open or, ripped open basically. Insulin helps with reducing infection with tight glucose control. And then your activity restrictions is going to be really big. So patients cannot lift more than 10 pounds for 6 to 8 weeks while that sternum is healing. No driving for 4 to 6 weeks because we don't want to get in a car accident and break that sternum. They will be probably tired and fatigued. This is a normal recovery thing. But what they shouldn't have is any signs of infection, like any fevers, drainage, or redness around that incision site. They should do diet modifications like a heart healthy diet, start light exercising to really improve those long-term outcomes. Okay, cardiomyopathy is a disease of the heart muscle. It causes that myocardium to become weak, enlarged, rigid, or thickened, which leads to that inability for that heart to pump effectively and distribute the blood throughout the body. Over time, it can lead to heart failures, it can lead to arrhythmias, and it can lead to sudden cardiac death. For your types of cardiomyopathy, there is dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. You're going to go more in depth on cardiomyopathy in complex care, but just know that it can cause the ventricles to become enlarged and weak. It can become stiff on the walls of that ventricle. And so the main thing with cardiomyopathy is that there is a decrease in cardiac output. So your patients will have symptoms of decreased cardiac output, like weakness, fatigue, edema, weight gain, syncope, palpitations, chest pain, that jugular vein distension, especially if it's a right-sided heart failure that's resulting from cardiomyopathy, or S3 heart sounds, which is an indication of ventricular overload. For our patients with cardiomyopathy, oftentimes an echocardiogram, chest x-ray, EKGs, your BNP, and your cardiac MRI is used to look at the heart, look at the ventricles, look at the wall thickening, and kind of see what kind of cardiomyopathy it is. Our treatment is aimed at improving cardiac output and reducing workload. So oftentimes we get medications for that. So we will give beta blockers, ACE inhibitors, and ARBs to decrease that afterload and workload. Diuretics given to decrease fluid overload so our heart doesn't have to work as hard. Antidysrhythmics like amiodarone, which helps control any arrhythmias. In dilated cardiomyopathy, we'll give anticoagulants to help prevent clots. We'll do lifestyle changes, so they'll be on a fluid restriction and low sodium diet, because remember, salt loves water. And they may get an ICD or a pacemaker or a heart transplant if they have severe cardiomyopathy. For our patients, make sure we do strict I&Os, give them medications, don't overexert themselves, educate on signs of worsening fluid overload. So that would be an increase in weight, We're making sure that they don't gain 2 to 3 pounds a day or 5 pounds a week. If they do, call their doctor. If they have any worsening shortness of breath or dyspnea, they would need to call their doctor. Also assessing their lung sounds to see if there's any fluid buildup from the inability for the cardiac output to be enough. You'll go more in depth on cardiomyopathy in complex care, but just know the basics of this. Okay, so pericarditis is an inflammation of the pericardium. This is that sac that surrounds the heart. Normally, the pericardium contains a small amount of fluid that helps to lubricate the heart as it moves and beats. But when that sac becomes inflamed, excessive fluid may accumulate, which can cause pain and impaired heart movement. So pericarditis can be sudden or it can be chronic, and it can lead to what's called cardiac tamponade, which is a complex care thing that you're going to talk about. But cardiac tamponade is essentially where that heart is blocked off and blood flow stops. So it's a life-threatening condition. For your pericarditis, this can be due to an infection. Viral infections are your most common. Bacterial infections or TB can also cause it. A lot of patients will get this if they have used IV medications, like IV drugs in like heroin or things like that, like illegal IV drugs, not good drugs. They can get it from recent chest trauma or surgeries, autoimmune disorders, or cancers. For your patients, your clinical cues that you're going to tie with pericarditis is going to be a sharp stabbing pain. Pain is worse when the patient is sitting up and leaning forward because that heart is going to go towards the chest wall. And then they will have a pericardial friction rub. So that's a high-pitched, scratchy sound that's heard at the left sternal border. So it's kind of a high-pitched, like a balloon rubbing on each other is what you'll hear when you're listening to the heart sounds. For your patients, we're going to check it with a chest x-ray to look for cardiac silhouette of fluid buildup. Maybe do an echocardiogram, look for ST elevation, those kinds of things for that cardiac problem. Again, I'm not going to test you on cardiac tamponade, but that is a life-threatening emergency that's due to that rapid fluid accumulation that compresses that heart and stops the heart from bleeding and decreases cardiac output. But that's a complex care situation we're not going to talk about. For your patients with this, we want to figure out the cause. We can give NSAIDs to decrease inflammation, aspirin to help with pain and decrease inflammation, corticosteroids for autoimmune causes. If they have a bacterial infection, they're going to get antibiotics. And we want to just kind of assess the cause. For these patients, we will avoid the use of anticoagulants because this increases the risk of bleeding and can go into that pericardial space.
Okay, so we're going to talk about chronic CHF, so congestive heart failure. CHF is a chronic condition where our heart is unable to pump enough blood to meet the body's oxygen and nutrient needs. So usually what happens is that heart either can't pump effectively due to different types of causes like hypertension, MI, cardiomyopathy, or different problems with the actual makeup of the heart, like the valves or the heart walls that we've talked about. And so that fluid, that blood backs up and that fluid accumulates. And the fluid can accumulate into the lungs and into the body tissues. So there are two different types of heart failure that we're going to talk about throughout the next couple slides: left-sided heart failure and right-sided heart failure. Most of the time, what we see in our patients is going to be signs and symptoms or cues that relate to poor perfusion, an excess accumulation or a fluid volume overload, and the inability for oxygen to be adequately delivered to that tissue. Okay, so for our CHF, what we do to diagnose this is we're going to do a really good nursing assessment. So we're going to do things like looking for excessive fluid on the body. So we're going to look at lung sounds like crackles or wheezing that can indicate excess fluid buildup. Do our daily weights. So because water weighs very heavily on a patient, we want to look at their fluid volume status and look for that fluid volume excess that they might have. Any peripheral edema, vital sign changes, so hypertension and those kinds of things that would indicate a fluid volume overload from the heart not being able to effectively pump it out. Oxygen saturation, so our patients would have low oxygen levels. They may have mental status changes because of that low perfusion, and then our labs would be out of whack. So one of the things that would be elevated would be a BNP. This is our marker for CHF that shows that CHF is occurring and that it's a high elevated level. Diagnostic test for it also would include an echocardiogram. So this looks at our ejection fraction. Is our heart able to effectively pump the fluid out of our heart? So for our normal ejection fraction, this is 55 to 70%. That's normal, that's effective. In a patient with heart failure, because that heart's not able to effectively pump and get that fluid off and that blood pumping, they're at less than 40%. So that's our gold standard for that. We may also do things like chest x-rays to look at fluid in the lungs to see if it's a backup into that lung tissue for that fluid. We may also do a chest x-ray to look at the configuration of the heart or the size of the heart. They may sometimes do a stress test just to see if that places extra stress on the heart, looking for fluid buildup, and then our EKGs to look for any electrical impulse arrhythmias. For our patients, our nursing interventions for heart failure, what we want to do is we want to get rid of that fluid. So first thing is going to be diuretics. Now with our diuretics, because we're getting rid of the fluid, we want to monitor electrolyte status, especially potassium levels. We will do some medications to help with heart rate control, like ACE inhibitors or ARBs. We may do digoxin to help with the contraction of the heart, making sure it's strong enough to get that fluid out of the heart and pumped throughout the body. We will limit that sodium level because remember, water follows salt, so that low sodium diet is essential. And then we will place them on a fluid restriction. We usually will do a 1 to 2 liter fluid restriction per day, depending on severity. Making sure we do our good assessments, making sure we listen to lung sounds, we look for any pulmonary edema that could be occurring from that overload of fluid, and that would be indicated by pink frothy sputum. So that's our trigger word for pulmonary edema. Okay, so we talked about two different types of heart failure, left-sided versus right-sided. So when we think about that, we got to recognize some cues of each individual type. So when we're looking at left-sided heart failure is where it affects the lungs. So when we think left L, think lungs. So this can occur from that systolic failure where that heart can't pump effectively, reducing that ejection fraction, or it occurs during the diastolic phase where the heart can't fully relax and fill properly. So we have a preserved ejection fraction. For our left-sided heart failure, we're going to think symptoms that refer to the lungs. So this is going to be dyspnea, like shortness of breath, orthopnea, shortness of breath when laying flat, some crackles in our lungs, changes in lung sounds, pulmonary edema with that pink frothy sputum, and fatigue from shortness of breath. For our right-sided heart failure, we're going to think our right-sided heart failure, rest of the body. This is going to be things that we're going to see throughout the entire body. So that's going to be things like peripheral edema, jugular vein distension, a buildup of fluid in the abdomen, that ascites, an enlarged liver, so hepatomegaly, and weight gain throughout the body. So to be aware of our differences between fluid volume excess and fluid volume deficit, I've got these two slides. This is important to know what you're going to see in your patient if they have a buildup of fluid, but that's going to be things like our respiratory changes, that fluid buildup, so edema throughout the body, and this can be usually pitting, especially with severe fluid volume excess. They're going to have changes in their electrolytes, so potassium and sodium levels are going to be elevated. Our patients will have potential for that pulmonary edema, so buildup in that fluid lung tissue is going to damage that lung tissue. So they're going to have pink frothy sputum from that blood tinging the mucus and the fluids. They're going to have severe shortness of breath, maybe a feeling of impending doom, and so we'll want to notify the doctor right away with any risk for pulmonary edema. Fluid volume deficit, on the other hand, is going to be our patients that are dry inside, and so these patients will have changes in vital signs usually. So usually our first indicator is going to be a change in our blood pressure, leading to hypotension, so our blood pressure is too low because there's not volume in the tank. And then our heart rate increases and becomes tachy because it compensates for that lack of volume. The body panics and says, I better beat faster to get the amount of gas I have in the tank throughout the body since it's not enough. Mental status changes can occur. This is usually in relation to sodium levels. So anytime you see sodium levels out of whack, you're going to think mentation neuro. So they'll have mental status changes. They're going to have a decrease in urine output, so below that 30 mLs per hour. Fluid volume is going to be decreased throughout the body, so we're going to see dry mucous membranes. They're probably going to be dry, thinner. They're not going to have edema buildup or that fluid buildup, and they're not going to have changes in their respiratory sounds. So they're not going to have crackle lungs. They'll have normal lung sounds. For our patients, making sure to treat the underlying cause, rehydrate them, and assess for any safety-related falls or anything like that for fluid volume deficit. Okay, now we're going to talk about peripheral vascular disease, or PVD. There are two different types of disorders that fall under the umbrella. There are peripheral artery disease and peripheral venous disease. So we're going to talk about the arteries and the veins. So remember, arteries carry blood away from the heart, and the veins carry blood to the heart. So it's deoxygenated blood and oxygenated blood. When they have problems with the vessels, arteries and veins, the blood's not able to effectively move to the tissues and away from the tissues, and so different types of problems can occur, and we'll talk about that on the next couple slides. Okay, so we're going to start talking about peripheral artery disease. So this is a narrowing or blockage of those arteries in the peripheral extremities, and this is commonly caused by a buildup of plaque, arterial sclerosis, so a narrowing of that artery. This leads to a decrease in the blood supply to the extremities. So think about that. If there's a blockage or something that's not letting the blood go all the way down to the toes, all the way to the little extremities, then the patient's going to have a lack of circulatory system, lack of blood flow down to those extremities. So what we're going to see with that is going to be cold, pale skin because that blood's not down there keeping it warm. They're going to have a weak or absent pulse because that blood's not down there in those pulses beating against the vessels. They're going to have pain at rest, which is usually worse at night. And then they're going to have ulcers, usually found on their toes, and these are going to have smooth edges, and that's because there's necrotic tissue from lack of blood flow. So that's what occurs there. Now, on the other hand, we have peripheral venous disease. So this is a problem with our veins. Our veins typically help to return the blood to the heart, so it's deoxygenated blood. They have a lot of little valves and things that help move that blood up the legs to the heart, so it prevents backflowing or pooling. But what happens with these veins is they're stretched out, they're weak, they're thin, they're diseased due to problems in the patient. So a lot of times this is due to diabetes. It can be from COPD or smoking problems, things that damage those vessels. And so that blood's not able to return back to the heart. And so what happens is it starts to pool. Now, when we have blood that starts to pool, it starts to coagulate, those red blood cells start to break down, and this causes the signs and symptoms that you're going to see in peripheral venous disease. So we're going to have warm, swollen limbs. The blood is there, so it's keeping it warm, but it's excess fluid, so it's going to be swollen. It's going to have that brown discoloration. This is due to a breakdown in those red blood cells. So the red blood cells break down and die, and it changes that skin coloring to a brown discoloration. Patients may also have edema because of that excess buildup of fluid, and then they might have some thick skin. So it kind of looks like elephant skin almost, that thick, kind of scarred up looking skin. This is because the skin tries to repair itself. It becomes weak and brittle, and so the body starts to repair the skin, but it builds up that scar tissue, and then repeated breakdown of the vessels just continue to occur, and those layers of that scar tissue start to build up, so it becomes kind of thick and scaly looking. We will have stasis dermatitis, so that's skin discoloration, that rough colored skin and breakdown, causing those ulcers. Typically, this occurs around those ankle joints and bones, so the malleus bone. And also, the ulcers that you'll notice are going to have irregular edges due to that venous problem, the inability for the blood to return. Okay, so here we have a picture that compares and contrasts the pulmonary artery disease versus pulmonary venous disease. So if you see, one extremity is going to be cool and pale, one is going to be hot, warm, and colored red. One is going to have edema, one will not. One will have pain with movement, one will have an alleviation of pain when they're not moving. One will have sores on the toes and bottom of the feet, and one will have it kind of up on the ankle area. One will have round, smooth sores, and one has sores with irregular borders. So just remember what's going on in the body. Arteries bring blood down to the extremities. Veins would bring it back from the extremities up to the heart. So kind of think about what's occurring in that pathophysiology to think about your cues. Okay, so now we're going to talk about DVT, or deep vein thrombosis. So a DVT is a blood clot that forms in one of our deep veins. Usually this occurs in our legs, in the calf or thigh area, but it can occur in our extremities. And so we will see that, but usually we see it in the legs, the calf or the thigh. So the problem with our DVTs that we worry about, that is our big NCLEX safety thing, is that those clots can break off and they can travel into our lungs and cause a PE, or pulmonary embolism, or they can break off and go to our brain and cause a stroke. So DVTs usually will occur when we have things that prevent our blood from normally flowing. And so it causes clots, because remember, blood that sits still starts to clot. So venous stasis that we talked about, that prolonged immobility, heart failure, bed rest, long flights, anything that prevents our veins from being able to get that heart back up to our blood and pump through appropriately, can cause those clots to occur. We can have hypercoagulability. So this is problems with our clotting factors. So this can be occurred by cancers, smoking, dehydration, or genetic clotting disorders. One big one is our oral contraceptives, especially if they have hormone therapies in them. So that's a big risk factor for DVTs. Anything that leads to endothelial damage, like traumas, surgeries, inflammation process, anything like that can cause the blood to clot. So for our DVTs, most of the time for our signs and symptoms, initially it's silent, so we don't know that we have it. But what we can occur, and the classic symptoms that are trigger symptoms for DVTs, are going to be things like unilateral swelling in the extremity. So one leg is more swollen than the other. There's warmth or heat in that affected area. There's more redness or discoloration occurring. And then we have pain or tenderness, oftentimes in the calf. We can palpate lightly, and we may feel a firmness or a hard vein, but overall, we don't really want to manipulate that area too much because we don't want to dislodge the clot. So we no longer have them flex their heels and move their leg around. That's pretty outdated. So if we see any redness, warmth, discoloration, the patient complains of any pain, what we're going to do is we're going to do a venous ultrasound. So we're going to look at the veins through an ultrasound. This is non-invasive, doesn't hurt, and it will show if there's any clots in there. We also will assess and take a lab level called a D-dimer. This can elevate if there's clot formation. This is part of our clotting cascade that we see, but we may see that, that's elevated. Sometimes it's not. So for the most part, our gold standard is a venous Doppler ultrasound to look for that clot. Now, our nursing interventions for this is that we assess the patient, we get that diagnosis, and then we start treatment. So we're going to prevent that clot from getting bigger by giving anticoagulants. So usually a heparin drip or subcutaneous heparin is given. Our patients may get Lovenox as well, or warfarin. So usually what we'll see is we'll do the heparin for a while, and then we'll do a bridge to that warfarin level. We want to avoid massaging the legs, so no SCDs on the patient. Avoid them getting up too much. We don't really bed rest them anymore like we used to. We can walk them, especially if that clot is, under a certain size. Monitor for signs of bleeding with that anticoagulant. We want to go ahead and improve venous return, so we'll elevate the leg. We can put compression stockings on, but only after that anticoagulation is started and the patient doesn't have any severe pain. And then we can encourage that light gradual ambulation once that the anticoagulant is on board. Always watch for signs of a PE or a clot to the brain. So we're going to assess chest pain, shortness of breath, tachycardia, bloody cough, low oxygen saturation, changes in mental status, all of our signs and symptoms of our strokes. So making sure to educate on reducing our risk for a DVT. So patients should remain active, get up and walk on long flights, stay hydrated, use compression socks if needed, stop smoking, and making sure that the patient has a good diet and everything. For our patients that take warfarin, we will need to monitor their INR and make sure that they keep their vitamin K consistent, because that can change their levels of warfarin in their body. Avoid any NSAIDs and herbal supplements that might increase that bleeding, and just basically monitor for signs and symptoms of worsening risk factors for DVT.
All right, so a common thing to talk about is hypertension. So we see patients all the time with hypertension, but it's important to know what we're looking for, why we're looking for it, and what we do about it. So hypertension is essentially abnormally high blood pressure. This can cause that heart to work harder to pump blood and can lead to symptoms in our patients. Oftentimes it's called the silent killer because our patients don't even know they have it until serious complications occur. So for our patients with hypertension, this is defined as anything that is greater than 120 over 80 on a blood pressure scale. There are some different levels of hypertension. So normal blood pressure is 120 over 80. Elevated hypertension or elevated blood pressure, or pre-hypertensive, I guess you could say, would be 120 to 129 over 80. For our stage 1 hypertension, this would be 130 to 139 over 80 to 89. Stage 2 hypertension would be anything greater than or equal to 140 over greater than or equal to 90. And then for our patients with hypertensive crisis, which means we got to get them some care, some meds on board, we got to do something about it, would be anything greater than or equal to 180 over greater than or equal to 120. So essentially hypertension occurs because there's that increased pressure against those vessel walls. This can damage those vessel walls. This can lead to inflammation and plaque buildup, which can lead to an increased workload on the heart. So this can lead to hypertrophy. It can lead to heart failure, and it can lead to death. It can lead to stroke. We talked about that in our neuro lab. So for our patients with hypertension, if they're having clinical manifestations, it could be things like headache, dizziness, vision changes, chest pain, nosebleeds. But for the most part, uncontrolled hypertension is so dangerous because most patients will feel normal. Now we have some of those non-modifiable and modifiable risk factors. They are the same as other cardiac things we've talked about. Modifiable would be high sodium diet, obesity, stress, diabetes, smoking, alcohol. Non-modifiable would be your age, family history, race, specifically African Americans, and gender. Men are usually earlier. For our patients with uncontrolled hypertension, it can affect all of the organ systems of the body. So it can affect our heart and lead to heart failure. It can lead to stroke or TIA in the brain. It can lead to that chronic kidney disease and kidney failure. It can lead to blindness or retinopathy in our eyes, and it can lead to aneurysms or peripheral artery disease in our vascular system. So hypertension crisis requires immediate reduction of that blood pressure. For the most part, we're going to give some medication. So that's going to be things like beta blockers, ACE inhibitors and ARBs, calcium channel blockers. This helps to vasodilate and decrease that heart rate and workload, and helps to relax vessels. Vasodilators can directly lower that blood pressure. Thiazide diuretics are our first line and help to reduce blood volume, or fluid volume. So it helps to diurese those patients. For your ACE inhibitors, one tricky thing is it may cause a dry cough, and in that case, patients can switch to an ARB. Beta blockers can sometimes be contraindicated in asthma and COPD patients because beta blockers work both on the heart and the lungs. So remember those two things, and NCLEX loves to test on that.
For our hypertension management, we want to make sure that we educate on lifestyle changes, medication adherence. So we want to do our beta blockers, ACE inhibitors, ARBs, calcium channel blockers, things that can help reduce that blood pressure, making sure our patient takes it consistently. Lifestyle changes would be increase in exercise, decrease in weight, changing their diet. So low sodium diet will really help with that blood pressure control because water and sodium correlation, and just making sure that the patient keeps a diary or manages their blood pressure, takes their blood pressure every day to make sure that they're managed at home for that hypertension.
Here are some common cardiac medications to be aware of, their purpose, and some considerations to be aware of. So for example, digoxin, one thing that NCLEX tests heavily on is vision changes. So with digoxin, if the patient starts to have a high level, they build up a toxicity to it, they will have a yellow, hazy vision. Your nitrates like nitroglycerin, again, it vasodilates, which can lead to a headache. That is a common known fact, and so that's not an emergency, but that vision change or yellow vision with digoxin would be an emergent situation. For your cardiac medications, make sure you're checking heart rate and blood pressure to make sure it's within safe limits, as well as our potassium levels. So anytime you see potassium out of whack, remember that will affect our cardiac system.